Welcome to the Virtual Lung Cancer Summit, sponsored by the Johns Hopkins University School of Medicine at Oncology Care Live. My name is Gregory Riely, and you are tuned in to a live session called Recent Developments in Targeted Therapy for Non-Small Cell Lung Cancer with Dr. Kris. Dr. Kris is a medical oncologist who specializes in the care of persons with cancer arising in the chest, including lung cancer. His research interests include tests for new anti-cancer treatments, the discovery of medicines that specifically attack lung cancer, multimodality therapy, and better ways to control physical symptoms caused by cancer and cancer treatment. Before we get started, I'd like to remind you that we will be taking questions in real time throughout this presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen, and we'll try to answer them during the course of the talk. So I'll turn it over now to Dr. Kris and tell us about personalizing therapy for advanced lung cancer.
Thanks, Greg. You know, it's just been an amazing time in the treatment of this disease. So many things have changed and changed for the better. Being a medical oncologist, it's just very gratifying how we can really impact patients' lives in a positive way and really how we can cut down on many of the disruptions that our treatments have fostered. In many ways, the treatment of lung cancer has become a poster child for personalized therapy of cancer in general. And what I'd like to do today is to share with you some of those developments and particularly focus on ways that you can use information to make better choices for your patients and also lead to the best outcomes for them with the minimum toxicity. We've worked long and hard as a community of specialists and researchers in lung cancer to develop the treatments we have today. We've taken a long road from no therapy at all to single agents, multiple agents with traditional chemotherapies. But what has happened, as you can see on the slide here, is that no matter how many drugs we used, and even adding in a newer agent like bevacizumab or cetuximab, we plateaued in terms of response rate at about 35%, in terms of survival at 1 year about 50%, and 2-year survival at 23%. And sadly, that plateau in survival at 2 years was that achieved with 2 drugs, and adding in a 3rd drug, or bevacizumab, really didn't help that very much. Where we had a very dramatic difference was in those last 2 rows that you see in this slide. That when we found an important target, a driver mutation for this illness, and when we had a drug that very effectively blocked the effects of the activation of that target, we had a dramatic benefit to our patients. So you see a doubling of the rates of response in the 70% range, almost a doubling of the 1-year survival, and more than a doubling of the 2-year survival. So this has given me the impetus to look more and more for drivers that truly are important in lung cancers, and then also drugs that block the effects of those drivers. I should mention that there are a lot of mutations, but not all mutations are driver mutations, and we'll talk more about that with EGFR in just a second. One thing that we have done now, and this is a growing effort by a lot of specialists, particularly our pathology colleagues, is we've changed kind of the way we look at lung cancers now. And I have here sort of a new wave pie. One thing you see missing here is that term non-small cell lung cancer. It actually was never a good term. I think a much better way to look at it here in terms of histologic subtype is like you see here. Adenocarcinomas, approximately 60% of lung cancers, squamous cell 20%, small cell 13%, and the other cancers less. I think this is a really good way of looking at it, the illness. It's also a good way of choosing therapies because our therapeutic choices are based really not on non-small cell or small cell really at this point, but more on the specific cell type, particularly with squamous and adeno. A reminder as well, because this is such a common illness, even 1% of adenocarcinomas is roughly 1,400 patients a year in the United States alone. Again, putting things in perspective, there are probably 2,500 mesotheliomas each year, 5,000 cases of chronic myelogenous leukemia, 20,000 cases of ovarian cancer. A few percent of lung cancer is a very significant disease in the U.S. What I'm showing here is the first page of the newest version of the NCCN guidelines. This went live about a week ago. It is generally similar to the earlier versions of the guidelines, but there are a few changes here. Talking about the cell types of non-small cell lung cancer first, the first step on this guideline, on this pathway, is the accurate definition of the specific cell type of the illness. I can't emphasize how important that is, and also how much more precisely our pathology colleagues are able to tell us whether it's an adenocarcinoma or a squamous cell carcinoma. In many reported series from individual pathology departments, the number of patients called large cell or called NSCLC, NOS, has gotten very, very small, particularly by the use of standard immunohistochemistry tests that are available in virtually every pathology department across our country. So we have adenocarcinoma, the vast majority of cases, squamous cell, and very few in between. From a practical standpoint, the types other than adeno or squamous are treated as adenocarcinoma, but it's a vanishingly small number. For those patients diagnosed with adenocarcinoma, the recommendation is for routine testing for EGFR mutations and ALK rearrangements. A corollary in here is that if you do not have adequate tissue, that it is possible and recommended that you consider another biopsy for that patient. This too is becoming less of an issue because our colleagues in pulmonology, thoracic surgery, and interventional radiology know that we need sufficient tissue to give an accurate histologic diagnosis and to permit mutation testing. So more and more patients are arriving in our offices with adequate tissue specimens to get the molecular data and well as the accurate histologic assessment. For squamous cell, the specific targets for squamous cell lung cancer, and I'll talk about them later, are being discovered, and there are some squamous cell specific targets now. However, there are some special groups of patients, though, that despite the diagnosis of squamous cell, will likely benefit from doing the adenocarcinoma panel, and that would be mainly EGFR and ALK testing. And those would be patients with, that are never smokers with squamous cell, and also those patients where the diagnosis of squamous cell was based on a very small specimen. Very often the entirety of the morphologically heterogeneous nature of a tumor may not be able to be seen, and there may be large areas of adenocarcinoma that just can't be seen on a small specimen. So when the specimen is small, when the squamous cell is diagnosed in a never smoker, I think the recommendation now is that you would consider mutation testing in those patients as you would with adenocarcinoma. I think all of you are familiar with how we use these pieces of information. We use it to select drugs, the choice of pemetrexed in adenocarcinoma, conversely the choice of gemcitabine in patients with squamous cell. We use it for safety reasons with bevacizumab. Bevacizumab safe in patients with adenocarcinoma, not so in patients with squamous cell carcinoma. And other agents, based on the literature available today, activity comparable in both squamous cell and adenocarcinoma. But I do believe, and particularly with the pemetrexed and gemcitabine by the different cell types, you can make huge differences here. And here's an example of from the trial by Giorgio Scagliotti. A 2-month difference in median survival based on the choice of pemetrexed for adenocarcinoma, and conversely based on the choice of gemcitabine for patients with squamous cell carcinoma. So these histologic characterizations, they do matter in terms of important outcomes for our patients, and more these designations are being made more precisely, and I think are becoming part of standard care, and our guidelines reflect that now. A huge development that happened almost 9 years ago to this day was, at least at our institution, the discovery of mutations in EGFR. Up on the top here, you can see a tumor that shrunk with gefitinib, and as it turned out, when we analyzed that person's tumor, we were able to find a mutation in exon 19 of the EGFR gene. Gefitinib is a very specific blocker of the EGFR tyrosine kinase. It really does little else. And one of the causes for kinase activation would be mutation. And lo and behold, when we looked for mutations right in that kinase gene, we found them there. And this opened up a whole world of new possibilities, and I'll detail some of them now. Dr. Riely, sitting across from me, put together this paper in clinical cancer research a few years back. And the point of this, and I'm sorry it's a little complicated, but it shows the different types of EGFR mutations that can be discovered. I know we're all faced with these reports, and many of the reports, particularly those that use a direct sequencing technique, find every mutation. The top row, the G719, LREA deletions, and two point mutations in exon 21, L861 and L858R. Those are uniformly agreed to be sensitivity mutations. So if you have one of these mutations in your tumor, you can virtually guarantee some benefit to the patient, response rates, some kind of a shrinkage in probably 90% of patients. I'll go to the bottom where you see most of the different mutation types. Those mutations do not impart sensitivity. So I think you have to be very careful when you receive a report and you find a mutation in EGFR. You say, aha, it's an EGFR mutation, but the vast majority of mutations, as you see here, do not impart a sensitivity to the drug. In the middle there are a group of mutations in exon 20. In exon 20, those tumor cells that under the selective pressure of gefitinib or erlotinib become resistant to those drugs, they develop a second site mutation, just like in chronic myelogenous leukemia in T790M, and that is a resistance mutation. They're very rarely found de novo, but they can be. What you also see there is another abnormality in exon 20, insertions in exon 20. Those two are not examples. It's not a mutation that occurs in the acquired resistance setting, but exon 20 insertions are not sensitivity mutations. They compile almost 10% of EGFR mutations, actually. So it's very important when you get that report to make sure it's a sensitivity mutation. And if it's not one of the sensitivity mutations, the best treatment strategy for that patient is chemotherapy. This trial, the IPASS study, familiar, I'm sure, to everyone here, is an important one. I just want to draw a few critical points from it. I think the first one is that this idea that there's a profile of who responds to gefitinib in this case, or erlotinib as well. Everybody on this trial was from East Asia, Japan, Taiwan, Korea, China. Virtually the vast majority of patients were women, and the vast majority were never smokers. But if, as you see there on the right, if you had all those characteristics, quotes, fit the profile, but did not have an EGFR mutation, gefitinib was not an effective drug, a 1% response rate. And when you look at the hazard ratio for the progression-free survival, what you see is that it approaches 3. So clearly no benefit and perhaps some harm. For those patients here, in terms of PFS and response rate, a better choice is chemotherapy. The EGFR mutation positive, just the opposite. But I want to focus on the response of those patients to chemotherapy. Please note there, the response to chemotherapy in an EGFR mutation positive is nearly 50%, twice that we saw in the mutation negative patients. Actually, it's one of the most potent predictors of chemotherapy response that have ever been discovered. Yes, gefitinib is even better choice, higher rate of response, yes, a PFS benefit. But if you're in that situation where you did not know the mutation status for whatever reason, or that you made the decision that the patient needed to be treated before that mutation testing results were available, chemotherapy is a good choice. But I take from this data, you can't take that risk of giving gefitinib not knowing, because if you're wrong, and even in this population, a good 40% of the people do not have mutations, you give an ineffective therapy and do much better with standard chemotherapy. And that's the recommendation in the NCCN and other guidelines. The other thing about this mutation data, and again, just to to say a few more words on it is this idea that it's a phenomenon of East Asia, that it doesn't mean the same thing in the U.S. As it does in East Asia. What I show you here is data from a upfront trial by the Cancer Leukemia Group B group led by Passiane and Vincent Miller. This trial gave upfront erlotinib, and I focus on this EGFR mutation positive cohort. So we looked at this Euro-American group versus an East Asian group from the IPASS trial. Response rates virtually identical, 70%. You look at the progression-free survival, again, very close to each other. Actually, the U.S. group with erlotinib did a little bit better. And when you look at the overall survival, again, the U.S. and East Asian data, very, very comparable. So this idea that the drug works somehow differently in people in Japan or Korea is probably not correct. Yes, there are more people with mutations in those populations, and you see more benefit because there are more people with mutations that derive the most benefit. The other interesting thing actually is too, when you look at the specific kind of mutation, it's exactly the same. The incidence of exon 19 deletions was 54% in both the IPASS and the Euro-American trial. So the critical thing here is mutation, and I'll say it now and again a few times, there is no clinical selection criteria that is accurate enough to be used to select therapies with tyrosine kinase inhibitors for EGFR mutant cancers, in my estimation.
And while we're here on this slide, I think it's a good idea to hammer home again, which are the sensitizing mutations? What are the main ones that we think of as sensitizing mutations?
So the two most common ones are in exon 21, L858R, and in exon 19, multiple base pair deletions in exon 19. It's like exon 19 del is how it would appear. There are rare ones, G719 and an L861Q, but those are 5 or so percent. But
so really that 90% of L858R and exon 19 deletions, those are the sensitizing mutations.
Yes, and those are the critical ones. And the vast majority of the data is that if you don't have those, you're unlikely to benefit from a TKI and do better with chemotherapy. That's the take home there. People have said, okay, this is a very interesting phenomena. Maybe it happened in Korea, but is it going to happen in Kentucky? Okay, that was legit. And was it just a one-hit wonder? And as it turned out, it's not a one-hit wonder, and that's one of the most amazing stories actually in lung cancer. Some examples of this, and examples of the rapidity of taking a research finding to our patients. This is a paper that I never noticed, frankly. It was from the journal Nature, one of our most prominent scientific journals in 2007, and a group of researchers in Japan found that rearrangements of the ALK gene, fusions of EML4 and ALK in this original description, were indeed oncogenic. They led to constitutive activation of a kinase, and that was a driver mutation, another one of those drivers. As it turned out, there was a drug in clinical trial for MET amplification or MET dependency. This drug is crizotinib. This drug also was a very potent inhibitor of the ALK kinase and the mutated ALK kinase, and because it was already in clinical trial, it became possible to use it in patients. And lo and behold, it worked extremely well. That same kind of data like we saw with gefitinib and erlotinib in the EGFR mutated patients was seen in patients with ALK rearranged lung cancer, so-called ALK positive lung cancer as it's now called. And here is the amazing next chapter in this story. Remember that 2007 paper. On August 26, 2011, the U.S. Food and Drug Administration approved crizotinib for this group of patients, ALK positive lung cancers. They did it on the basis of 256 patients. They approved a companion diagnostic test as well. We'll talk more about that later. But the important thing here is, and my reason that I see for this very quick approval was the obvious benefit to these patients in terms of shrinkage, in terms of the degree of side effects. And it's just an amazing story when a very dramatic benefit can be seen. And here it was shown in another group of patients. These patients too that have rearrangements in the ALK gene, None of them have EGFR mutations, so it's an additional group of patients. Yes, it's a few percent. It's somewhere between 5 and 10%. 8 is probably the most common number quoted. But please remember, 5 to 8% of adenocarcinoma of the lung is somewhere between 8 and 11,000 patients per year that could benefit from this tablet chemotherapy. So what's happened is that we've found many of these drivers, and here is a list of the drivers that we have now and the various incidences of them. This is a paper that been put together by docs at our institution with looking at the instances of these different mutation types in adenocarcinoma. So how do you find these mutations? And let me just tell you the experience that we had at our institution and how we were able to do that. Our pathology department had been instrumental in helping discover EGFR mutations and in developing the test for EGFR mutations. We had a test in our pathology department in 2004 that we've been performing, and since then fairly routinely on patient specimens at the time of metastasis and also at the time of surgery. So our pathology department, after they make their definitive morphologic diagnosis, then extracts DNA from these tumor specimens and sends them for testing for all these driver mutations. And it's a organized part of pathology. It's some ways analogous to the way that when you have a patient with adenocarcinoma of the breast, you routinely receive estrogen progesterone status and now HER2 status. The same sort of reflex testing is what our pathology colleagues call this. And we put this in place for patients with adenocarcinoma of the lung. We're doing it now for the other types of lung cancers as well, and we'll talk about that. This is Mark Ladani. He was sort of the key person within our pathology department that was involved on the research side in the discovery of EGFR mutations and also on the implementation side, developing the test. And most importantly, Mark Ladani and Maureen Zakowski at our institution as well made this part of the routine in our pathology department, just like estrogen receptor and progesterone receptor in patients with breast cancer. This is the system that Mark came up with. The Sequenome is the name of it. There's another one widely used called Snapshot. But what this does is in one DNA specimen looks for mutations, 91 mutations in 8 genes. The Snapshot does a very similar type of what they call multiplexed testing. So one specimen gives you all these known driver oncogene mutations in a single specimen and gives you a quick readout. And this is what it looks like in a patient's chart. Again, all these mutations are tested for one time, quickly reported. The test is run twice a week at our institution. You get very quick turnaround. Actually, the delay here comes from the acquisition of the specimens and also the processing of the specimens for routine testing and then the DNA and getting the DNA to the lab. Once they have it, they can do it really literally the next day. This is a picture that shows the overall incidence of mutations. And first, what we found here at Memorial Sloan Kettering, the most common mutation we find is KRAS, 31%, EGFR here at about 23%. But I think the most important fact is we find some mutation that is a driver in 65% of cases. So when we do this testing, we find some piece of information that can be useful for care, particularly in terms of EGFR or ALK rearrangements, but also for research to guide patients with those mutations where we do not have a standard therapy toward research. People say, well, this is only something that potentially you could do at a research center, like Sloan Kettering. But what I have here is a list of all these different targets that we have and of drugs that we have available in our pharmacies now that could be used for this. So EGFR, we have erlotinib. ALK rearrangements, we have crizotinib. But crizotinib is also active with ROS rearrangements, also active with MET amplification. We have vemurafenib for BRAF mutant lung cancers, and we also have trastuzumab or lapatinib for HER2 mutated lung cancers as well. So yes, not all these drugs are approved for these indications, but they are available and they can be used, and I'll show you some examples of that later on. For those targets where we don't have an available drug or where we're trying to find better therapies, I have here and on the next slide a list of the various strategies we're using to look for additional therapies for these other targets. and I'll show you some examples of this as well. These targets are not just in adenocarcinomas. You see here on this list FGFR1, DDR2. Those are targets found in squamous cell cancers, and they're being added to this list. I showed you the Memorial Sloan Kettering experience of doing this upfront multiplex genotyping. We have worked together with 13 other institutions that shown here across the country to do this kind of multiplexed upfront testing together and to share information. It's called the Lung Cancer Mutation Consortium. We have completed the first 1,000 cases. We're now starting on our second 1,000 cases. And shown on this pie graph is a virtually identical picture to what we found at the Memorial Sloan Kettering experience. The numbers vary a little bit, but not all that much. We again found a driver here in 63% of these patients. Again, this is from 14 institutions, nationwide, adenocarcinoma specimens. I think giving confidence that this kind of testing, number one, is consistent across institutions. Number two, can be done in many different sites. And again, when you do this testing, you can guarantee finding some kind of a driver which can lead to some intervention for an individual patient. So what has all this led to? I think first is a rethinking of this illness. And you've probably noticed I've been doing this, hopefully since I started the lecture. It's not lung cancer, it's lung cancers. It never was lung cancer. We know an individual patient, some responded, some didn't, some had a long natural history, some didn't. It's a lot of different diseases. And the molecular characterization is one way of showing the differences. And I'm not showing you this information today, but each of those drivers has a somewhat different natural history. The most data is between KRAS and EGFR, and when you plot those different drivers out, they have a different natural history. The idea that, again, it's a one-hit wonder, it's a two-hit wonder, it's much more than that. Here's a patient with BRAF mutant lung cancer, a V600E BRAF mutation, the same one found in many patients with malignant melanoma. This is the drug dabrafenib. This is a trial led in the LCMC by Bruce Johnson, and you see a very nice response there that persists to this day. I lead a trial in the LCMC of dacomitinib, and this is a patient with a HER2 mutation. Again, a nice ongoing response to dacomitinib here. So when you find these targets, you can act upon them. An amazing story is this one, that in the last year, 3 more targets have become available. Each of these targets are mutually exclusive. So adding in to all the ones we found already, that 65%, the number has gone up even more. And equally as important, there are drugs either in research testing or available drugs for these targets that could be used to treat additional patients with these additional mutations. So as we start chipping away at that remaining 1/3 of patients where we don't have a target today, we're finding more targets and more importantly that they're actionable. Many of you were at the ASCO meeting this year and you saw the presentation by Alice Shaw of patients with ROS1 positive lung cancers. Here's a waterfall plot, not at all different from crizotinib or in the ALK rearranged or erlotinib in the EGFR mutated cases. Again, very common, potent, durable responses in patients with ROS1 positive tumors. And here's an example from our own institution of a patient receiving crizotinib for ROS1. By the way, a patient had already had chemotherapy, had been tested for the other drivers, and didn't find them, but when this new driver came, testing done, found the driver and shrunk the cancer. Here is information on the RET, another fusion gene. This is a RET patient with RET-positive lung cancer, in this case giving the drug cabozantinib and having a nice partial response, which has now been confirmed. So that story about the new drivers, it's not just a science project. It immediately leads to a new treatment for individual patients. And both of these, a year ago, we didn't know to test for these targets in these patients, let alone being able to offer them these treatments. And you've seen the benefits that have happened. And these kinds of observations have been done by others as well. So what's the future here? Well, I've spent a lot about that first pie on the right, the adenocarcinoma, but we're now trying to move into the other types of lung cancers, squamous cell and small cell. We have set up a similar system at our institution. Paul Pack the physician in charge at Memorial Sloan Kettering. Again, it's a different group of drivers in squamous cell cancer, not the same ones that we found in adenocarcinoma. So we routinely now get specimens from patients with squamous cell cancer at the diagnosis and test for those drivers that are found in squamous cell carcinoma. And lo and behold, we do find these drivers in tumor specimens. Again, this is not the TCGA. This is a project in persons that came to us for care. Here we don't have drugs for FGFR1 or PTEN loss or PIK3CA mutations, but we do have clinical trials we can recommend to these patients. Now these cases you see here were tested using what I'll call them now-gen sequencing. FISH for FGFR, immunohistochemistry testing for PTEN loss, sequenome for PIK3CA mutations. But we are on the threshold of a new generation, the next generation of mutation testing. By the way, all these events are mutually exclusive as well. And just as with the EGFR story, we have agents here, not standard agents, but clinical trials for FGFR1, for DDR2 with dasatinib, and BKM120 for PTEN loss or for PIK3CA mutations. I mentioned, though, that this next generation of testing. So here we have much more powerful, quicker, efficient testing of tumor specimens. That MiSeq in the middle can probably test for the presence of ED genes, looking for mutations and other molecular changes in 80 genes, and it can do so in just a few hours. Ion Torrent can do probably 50 or more genes as well, and also can give you that result the same day once it's prepared. These are machines that are available in research labs throughout the world and in many pathology departments throughout the country. And these will likely replace our current standards of direct sequencing, snapshot, and sequenome in the next few years. This is the list of genes we look at the MSK version of it, MSK Impact, developed by Mike Berger. Can't read it, but all of the genes that are relevant to lung cancer are in there, as well as genes relevant to other kinds of cancers. You'll find KIT in there, for example. So when we did that next-gen testing using Impact on those same specimens that I showed you before, not only did we confirm the findings that we have, finding a more efficient way of testing just in one shot, getting all the testing we needed, but we found additional mutations. And in this case, we found mutations in PTEN that we had not been testing for before. And just like with adenocarcinoma, we now have something in 2/3 of the cases. Again, here it's clinical trials, but eventually our hope is that the clinical trials we have ongoing now will lead to therapies here as well. I showed you the list of drugs that you have to use in patients that you found these molecular abnormalities. And just to show you something that is not an experiment but a real life happening, this was a patient that I had treated with BRAF V600E lung cancer. The person was not eligible for a clinical trial we had, having had a prior MEK inhibitor, and I wrote her a prescription for vemurafenib. She took that prescription to the specialty pharmacy that dispenses the drug. The prescription was filled, and she took it, and here's the result. So people say, well, I'm going to do these tests, but what do I do with it? Well, here's an example of that test result coming in and taking an available drug, in this case vemurafenib, giving it to the patient and having a great response for her, and allowing her to have a much better time, and giving her another option, and giving her, in this case, a very nice response. So this was done not on any research protocol, not because it was Sloan Kettering, because I just wrote a prescription, and this is something that other people could do as well. A couple final words about the different testing we have. I think I've shown you the NCCN guidelines. EGFR and ALK testing, it's standard for all lung cancers, I think except squamous cell, that is in smokers, and where they have large biopsy specimens, and probably in small cell today. The best testing is upfront, parallel multiplex testing. You need to look for all the drivers. Again, 2 out of 3 chance of finding a driver, but you have now 14 drivers to look for. You can't do one after the other. There's just not sufficient tissue, and frankly, it's not time effective for an individual patient. There is no clinical selection that works to decide testing, and I would say to decide therapy as well. The genie's out of the lamp now. You can't go back. You have to do these genetic tests to make the best decisions for patients. It's totally reasonable to rebiopsy. These decisions are so important for an individual patient. It is okay to rebiopsy. They're generally universally available and covered through the U.S. And next-gen testing is going to take over, and my prediction is in the next 5 years we're going to be doing that for not just all lung cancers, but for all lung cancers as well. This companion diagnostic, again, it's something we have right now, an individual diagnostic for an individual driver, but that's going to change. And this is the words of Will Powell from the ESCO meeting this year. The use of companion diagnostics will be obsolete in the near future, and that, in his determination at least, next-gen sequencing is the holy grail.
Just to clarify on that, the idea that companion diagnostics will be obsolete and next-gen sequencing, that's not to say that we won't be testing our patients. We will be using some sort of testing. The companion diagnostic, I think, is a specific FDA term that we're trying to get out of, I think.
It is, but what may happen is your companion diagnostic will be a component of one of those Illumina platforms.
Right.
So the BRAF determination using a MySeq or Ion Torrent, that will be the companion diagnostic, but it will be done in the context of getting the other 278 genes or the other 80 genes on the Ion Torrent.
Right.
So this is an example. Again, I'm sure that you've seen this across your desk. There's original direct sequencing for one gene. I show you there the memorial 8 genes in the sequenome, and that, again, it's from our pathology department. But what we're now getting is the 230 genes done on a HiSeq platform, and they're arriving on my desk every day, and I think they're arriving on yours, Greg, and probably on other patients as well. So to conclude, that one-size-fits-all era for treatment of lung cancers, it's over. What has made the difference here is that these drivers that we find are truly important to the growth of cancer cells. They are biologically relevant, and it was advances in biology that led to the discovery of these drivers, and advances in pharmacology and research that led to the development of drugs that effectively block the effects of those drivers. The targeted therapies are biology-based. This is different than we've ever had before, and it's really a fundamental difference. We need precise pathologic diagnosis. It's absolutely essential, and you got to have tissue for that. There's an even greater need now for adequate tissue. Test, don't guess. There is no patient profile that's adequate. No patient profile is adequate. You need to do multiplex testing at diagnosis to make the best decision, give the best drug up front. You need tissue again. Erlotinib, crizotinib, available drugs for these mutant cancers, and this personalized care for lung cancer. And just to end, back in 2005, in the infancy of this kind of work, I gave a talk, 2005 version of this, and Ron Blum, a medical oncologist from Beth Israel Hospital here in New York City, sent me this cartoon of a woman showing up at her pharmacist and saying, "Here is my sequence." What you see there on 2012 is an actual prescription that I wrote for this person. I wrote on there her mutation type and the drug, and sure enough, it got filled. So what could be, pie in the sky cartoon can become reality, and I hope I showed you there, make a big difference for a patient. Thank you.
Great, and thanks so much for that, Mark. So we'll go through a few of the questions now. We have questions on molecular diagnostics. We have a couple questions related to immune therapies that we'll go through kind of one at a time. So if you have a patient, oftentimes you see patients in clinic who have EGFR mutant lung cancer. They've been treated with erlotinib and they're doing well. Now I hear that crizotinib or ALK rearrangements happen in mostly never smokers. EGFR happens mostly in never smokers. Is it worth going back and testing that patient who has an EGFR mutation to see if they have ALK so that you could then give them crizotinib?
No. So I think right now the answer is no. Where we finding a mutation is generally a good example of the adequacy of tissue. And if you have a good specimen and you found an EGFR mutation, it is extraordinarily unlikely that an ALK rearrangement would be there, or a ROS1 with the other, or crizotinib sensitive a driver would be there. So if you had a good specimen, you found a mutation, I don't think it makes sense to look for another mutation. It gets a little murkier where you didn't find a mutation. Maybe that was because you had an inadequate sample, and that can happen. And it may be that in those cases, thinking about testing, like just doing it again and making sure, I think that might be some sense. But if you have it, I wouldn't do it.
Okay, okay. So the positive result trumps things, and they're generally, these driver mutations do not overlap one another.
That is absolutely true. One thing we've done in the LCMC is we have performed every test on every specimen. We have over 700 patients where we do that. And so far, for the common mutations, we just don't see any significant overlap. We do see some overlap. It's mainly with PIK3CA and other driver mutations. We're not sure exactly what that means, and we're trying to sort that out now.
Got it. And P53, how does that work into all this? P53 is a gene we've been talking about for a long time. Where do we see this in lung cancer?
Yeah. So P53, LKB1, tumor suppressor genes found very commonly in lung cancer. I've seen numbers greater than 50% of lung cancers have these tumor suppressor genes. They are not these drivers. That's a little complicated though, because obviously by the loss of that tumor suppression, other pathways are activated. So what doctors are doing now is they're looking for the downstream effects of those tumor suppressor genes and trying to find the positive effects and then trying to block them. But as they exist today, they're not helpful in terms of selecting therapies. They clearly mean something. We know in experimental systems that when you have for example, a RAS mutation and a P53 mutation, that you have a different type of tumor. Clearly they change the context of the other mutations, but it's not an actionable thing right now. They're not drivers in the way that we say.
Right. So, and since a P53 is not a driver, it can overlap pretty clearly with EGFR and KRAS. You can see them together.
Yes, and it may mean something prognostically, and it may mean something therapeutically, but its effect is a more subtle one. It's like a contextual one, I like to say, and folks are going to work that out. Actually, that's an advantage of this multiplex testing now, because we're going to know P53 status on everybody, which we hadn't done on these specialized platforms like Sequenome or Snapshot.
Right. Okay. Let me just check and see if there are any molecular questions here. So one person asks, what's your recommendation about rebiopsy to obtain a new molecular profile at the time of progression on a targeted therapy? So you have a patient with an EGFR mutation. You give them erlotinib. They do well for 18 months. They're clearly progressing. What do you do at that point?
Well, at this point, there is not a specific molecular characteristic that can help us direct second-line therapy. We do this routinely for research, and we've done it at our institution. Actually, Vince Miller and Will Powell developed a protocol to do this, and you too, Dr. Riely. I think you actually did the work on that protocol under their direction. But they knew this was going to happen, and we started looking for that. And we've tested over 200 people on this protocol. And the same is true with ALK now. But getting a piece of information there that's going to direct therapy, we're not quite there yet.
But don't some of these patients develop a change in their histology at the time of resistance?
They do. There are a few percentage, somewhere between maybe 1 and 4, that have changes characteristic of small cell lung cancer. And there have been responses reported, sadly short-lived ones though, by giving etoposide, for example, to somebody with non-small cell lung cancer, something we would not routinely do. People have mentioned that as a reason to rebiopsy. I think it's legitimate to do that. Greg Oxnard, when he was working at Sloan Kettering, also looked at the the natural history of people with these T790M secondary mutations, and they had a somewhat less aggressive course of lung cancer, but still it was a fatal illness there. So it told you something about prognosis. But at this point, it's not a standard. We hope it's going to be, but it's not quite there yet.
Yeah, so you can get some prognostic and maybe rarely get some benefit in terms of treatment of small cell lung cancer. But beyond that, it's not a high yield maneuver.
I would put my effort on the upfront testing. That you're going to get the most information there, and over the life of a patient, you're going to be able to act on it in many ways. And I think with each passing year, you're going to have more options to act on that.
Okay. Now, one person asks about a patient with T790M at baseline. How do you treat those patients?
Yeah, well, that's a tough question. It is a very rare condition, and there is no potent literature that says if they're more sensitive or less sensitive than people without T790M. In general, it's a resistance mutation. In the laboratory, it is, and my personal experience is that it's been a resistance mutation. If benefit is seen, it's usually very short-lived and trivial, and I think chemotherapy is the standard of care for those people in my estimation. I don't know, Greg, what's your thought on it?
I think that's the right way to go. I think that, as you saw the data from IPASS, in patients with EGFR mutations, the response rate to carboplatin paclitaxel was 47%. Clearly, the 70% response rate to an EGFR TKI is better. It's not a lot better, and in those patients with T790M, the difference is probably not a lot, and so chemotherapy seems like a reasonable course to me. So let's change gears and talk just briefly about immune therapy. It's kind of not focused on the personalized medicine area as of yet, but I think it's something that we all think about. The person writing in reminds us there's a very moving story in the front page of the New York Times this week about a child with leukemia who has an excellent response to a cellular therapy that was developed at the University of Pennsylvania, and a number of institutions are doing this sort of cellular therapy where they modify T cells to somehow target a cancer cell. Now, I don't think anything like that's going on for lung cancer, but I think that the broad context of immune therapy is definitely an important one. Tell me just in a thumbnail about anti-PD-1 therapies.
Well, let's go back a little farther. The father of chemotherapy, how did he start? He started doing immunotherapy. And it's a idea that is well over 100 years old now to use immunotherapy for a lot of different diseases, cancer being just one of them. So it makes a lot of sense. And clearly, we know that cancers have found ways to evade the immune system. But we never could exploit that, I think, until just recently. We know that T cells are critical, and there's a very complex system of T cell regulation. And that when patients have cancers, the T cells that could kill that cancer they don't get to the site, they're disabled. A lot of different reasons, but bottom line, they don't work. I think we've seen good information so far about the use of anti-CTLA-4 agents, ipilimumab, in malignant melanoma, and there's some preliminary data in lung cancers as well. And now another T cell checkpoint active agent, PD-1, antibodies against PD-1 and PD-L1 take away that checkpoint blockade brought on by cancers. And there have been very nice, very durable responses to single agents with these drugs, and also so far, safety with chemotherapy. A number of institutions have studied that. One thing about these therapies, though, they are very likely to be targeted. For an antibody against PD-L1 to be effective, you need PD-L1 on the tumor cell. And if that PD-L1 is not there, that pathway is not relevant. You also need tumor infiltrating lymphocytes in those tumors. So if you have PD-L1 antigen on those tumor cells, you have activated T cells in that tumor, they're very responsive to these drugs. If you don't have it, they're non-responsive. It's almost like the EGFR story again. If you don't have the EGFR mutation, the benefit is trivial, whereas if you do, it's dramatic. And I think it's given us great hope. I've hopefully made a story about how far we've come with tyrosine kinase-based therapy and targeted therapies for specific oncogenes. But what I didn't show you today were any patients that are cured. Dramatic responses, long durations of response, much better tolerability and decency of life. But we're not curing patients, and we need a complementary strategy to our targeted therapies to do that, whether it be chemo or these immune strategies as well. I think everybody's very excited about this. A lot of these drugs are in trial, and I'll go so far, they're going to make it. It's only a question of in what context and when.
Right, and I think the targeting piece of that is going to be critical. We don't know yet what that target is or how to test for it. Is that right?
There's no established test. There's very little literature published on it. But again, but we know the biology of it is you have to have PD-L1, you have to have TILs to have these drugs to be dramatically effective, and we'll find ways of doing that. I'm pretty confident it'll happen.
Okay. Now, in the last few minutes we're here, let's focus just for a second on the process of getting that biopsy, getting that tissue to the pathologist, and then getting the pathologist to do the tests, and working closely with the pathologist so that we all do the tests that are right for the patients. How do you, I know that we often don't see patients before they've had their biopsy, but when we talk with folks about what type of biopsy to recommend, what do you say?
Well, what has happened in medical oncology has been very has changed how the persons doing biopsies have chosen to do those biopsies. I think more and more colleagues in interventional radiology, pulmonology, thoracic surgeries that do the lion's share of biopsies for suspected lung cancers know that we need more than cytology to make an accurate histologic diagnosis. And in addition, we need enough tissue for molecular studies. That's becoming a standard in those fields. I attended actually a meeting of interventional pulmonologists at the ACCP meeting this year, and that I did not need to tell them that.
That's great.
This interventional pulmonology community knows this, and when they go in to do a biopsy now for suspected lung cancer, the goal isn't just to, yes, it's of course to do an accurate diagnosis and to do it safely, but they know that they need to get sufficient tissue for good histologic determination and also for molecular. So I think that whole field is changing. It's still evolving.
Right.
And also there are some situations where it's, for safety reasons, you can't get that biopsy that you might need during a bronchoscopy, for example, or during a needle aspiration. And in those cases, I think a doc has to make a decision, is it worth it to do it again? And my estimation is it's almost always worth it, because it means so much to the patient.
Right. We've seen this is a critical decider about what you do in your first line of therapy, and if you don't have that data up front, then it'll help you when you hit second line.
The other the point is about pathology. What we have accomplished at Sloan Kettering and other institutions that have similar programs, the pathology department has been instrumental. And it's more than just doing the test. It's the entire package that a pathologist has. They are the caretakers of human tissues. They're taught to do that. They're good at it. They know that how to perform tests, how to do it accurately, how to do it within CLIA standards, how to develop those companion diagnostic tests. They're pathologists that do that. And we can't do this without them. We absolutely can't do it without them. And I encourage you to tap into their expertise, because they know how to arrange things in the pathology department to get the flow right. Nail the histologic diagnosis, do the state-of-the-art IHC test, get the specimen quickly to the molecular pathology part of their pathology department, or send it out as is their choice, get it to the FISH lab, get it to the IHC lab. How to prioritize these tests, only a pathologist can do that. One thing they need, though, from us is the explanation as to what the importance of these tests are.
Right.
pathologists never balk from doing a test that makes a difference in a patient's life. And we need to get that information to our pathology colleagues that this result will make a huge difference. Just like the diagnosis of cancer makes a huge difference, whether it's EGFR mutant or not is the same way. And we have to work with them and also tap into their experience. And the College of American Pathologists is doing that. You know, they partnered with the International IASLC to get this information out. This isn't specific to some gigantic cancer center either. I've heard a very eloquent presentation from Jan Nowak, who I believe you've met along the way, who is a community-based pathologist who has been doing these tests in his community hospital probably as long as we've done them at Sloan Kettering. And he can teach how that can be done in a community setting as well. That's the beauty of these things.
Absolutely. Well, thanks a lot, Mark, and thanks to our viewers for all the questions you wrote in. I'd like to thank Boehringer Ingelheim, Genentech, and Daiichi Sankyo for their support of this important educational series. Please remember to complete the quiz at the end of this session to secure your CME credits. My name is Greg Riely, and thank you again for joining us.